My project was titled Cesarean Section in the Urban Slums of Dhaka, Bangladesh. I want to assure you this was not C-sections in the slums themselves. It was in hospitals serving the slums, in case you were wondering. So I went here through the Fogarty program, which Duke is privileged and earned the right to continue that program. The NIH recently updated the grant, as well as work at ICDRB, where Dr. Merson actually started a lot of his career, and I'm certainly not comparing myself to him, but I was very honored to be a part of that institution, and a lot of what I was able to achieve and really to learn from my experience in Bangladesh was because of the phenomenal people there. I also worked with an organization called BRAC, which is a very large NGO in Bangladesh. They also work in several other countries, and certainly they were a huge part of making this study possible and starting to answer some of the questions that we're looking at here. So improvements in development and healthcare access characterize a changing Bangladesh. Socioeconomic improvements, reduced fertility rate, greater maternal education, improved community birthing practices. Women are going to facilities for childbirth or complications of childbirth. There's skilled care attendance. And then the final thing is women are using emergency obstetric care more often when they need it. Still actually in Bangladesh, 70% of women give birth without skilled access, so using a traditional birth attendant or at home. Among women who do have a skilled provider, about 50% of them end up getting a C-section. And so the question, a big question are these appropriate C-sections? In other words, are these women with complications who need C-sections, or are these not? I wish I could answer that question for you. It's a very technical question and one that's very difficult to answer. But one that we did want to look at was what are some of the consequences outside the medical consequences of having a C-section for women. In Bangladesh, in the last 10 years, the rate has gone from 3% all the way up to 17%. And in urban Bangladesh, it's now up to 30%. So there are increased medical risks as well as increased costs. In a private facility, a woman can pay $200 for a C-section. At home, it costs $5. And when you make less than $1.25 a day, that's a big difference. There's also poverty-related burdens. 60% of the under 5 deaths globally can be attributed to poor nutrition. And so it's something we need to look at. How does C-section affect nutrition in the household? Intimate partner violence. 42% of Bangladeshi husbands admitted to committing intimate partner violence in the last 1 year. So how does having a C-section affect whether women have intimate partner violence committed against them? And then postpartum depression. These things all, you can imagine, work together. So we sought to characterize some of these risks, but in whom? Urban slum dwellers. A third of the people in Dhaka live in the slums. 3/4 of the population moves into the slums each year. This is a growing population. So we wanted also to characterize C-section and say, why are providers doing this? What are the reasons they're saying that women are getting C-sections? So to answer these many questions, we had our study team, which you can see up here. I think it's like the only picture I got of myself during the whole year. Well, I didn't get it myself. On the left is an anthropologist. Sitting down is a sociologist. Standing up behind her is a MBBS physician. And then there's me, obviously, and we're at one of the medical colleges talking to people. So the study was, we did a cohort study of women. We looked at women who had C-sections and who had vaginal deliveries. And then we compared them in many different factors, medical, social, and economic. And we used a adjusted multivariate logistic regression. We collected information in 2 phases. One was in the hospital before they left. We had a survey. We wrote down things from the medical record. And then 6 weeks later, we interviewed them postpartum in the community. And BRAC did a great job helping us with that. So what did we find? We found that more than 50% of the groups had no secondary education, were below 20 years of age, were non-earning housewives, and lived below the World Bank's extreme poverty line of $1.25 per day. 2/3 had their first pregnancy as adolescents. On the bright side, nearly all had at least 4 A&C visits throughout their pregnancy. So this is a milestone that we try to achieve with women getting antenatal care. Things that we found. So C-section, there was increased non-specific maternal symptoms, increased neonatal infection rates, increased frequency of psychological intimate partner violence, and a decreased birth asphyxia. We also found increased household food insecurity and hunger in univariate analysis, but it dropped out in multivariate analysis, which is interesting to talk about. Postpartum depression screening, perinatal mortality, other forms of intimate partner violence, and other self-reported complications were not associated with C-section delivery. So we also asked the question, why are women getting these? 30% of women had a C-section for fetal distress. About 15% had it for labor dystocia, which is arrest of labor. And then about another 15% had the primary indication of having a previous C-section. That was the only reason that these women got another C-section. Together, these accounted for more than 55% of the C-sections done, and we tend to view these as lower risk women, though there are certainly caveats to all that. So conclusions, we need a better classification scheme. If you look up here at this cup, it's not beer, it's actually tea. This is a 7-layer tea. It's popular in a part of Bangladesh called Sri Mongol. Very beautiful. They have tea gardens up there. It's a local secret. They wouldn't tell me how they make it. I wouldn't be able to make it anyway. I'm not skilled in cooking or making tea. But you can look at this teacup in two ways. You can look at how full it is. And that's really what we know now. We know the rates of C-section. But we need to look at its layers. We need to say, what are the drivers of this? What are the consequences? And especially, don't lump all women who get a C-section into one category, because we can really look at the rates and seeing some of the consequences. Maybe it's something we need to start taking a look at. I do want to say, as someone who will be a medical provider, C-section is a life-saving operation that many women need. But as providers, we say first, do no harm. And so we need to consider more than just the medical harm.
Questions or comments for John?
Why do you hypothesize that cesarean sections are related to increased rates of intimate partner violence?
So Bangladesh is a 90% Muslim culture, and you hear a lot of anecdotes in Bangladesh that women, especially those who fight against going to the hospital, are often, their experience is romanticized. You hear about a woman who would lock herself in the bathroom and bleed to death, and she was considered a hero. And that's a very pervasive attitude. But it's interesting, when you actually do studies and get women away from that strong social pressure, many of them say the reasons they don't go is because they didn't know they needed to, or they didn't understand the urgency. And only about 6% really gave that specific cultural reason. And I didn't do that study, but I think that's really quite pervasive, and why with increased cost, the woman is, it was your failure. You failed at birth, and now we have to bear the burden of this. This is your fault. So I think psychological, it's a lot of either threats against the woman, threats to leave her, financial burdens, or demands from the family.
There's a stigma associated with C-section.
Certainly.
How big was that effect size on partner violence?
Let me look real quick.
Would you
It was-
characterize it generally as small, large?
It was about double. And interesting, our question, what I ran was not only that intimate partner violence occurred, but that the woman's perception was that it had increased since delivery. So it's a very prevalent thing. So it didn't go from 40% to 80% committed, but women were twice as likely to say that intimate partner violence psychologically had increased since delivery. That's a very survey, and there's a lot of problems with that kind of question, but I think it was interesting to see that women, not only that it occurred, but it had increased.
John, what a great study and a very good sort of interdisciplinary tool to get into a very complicated question. We think of C-sections in the States as driven oftentimes by medical legal concerns. I don't know if, I guess I got a two-part question. One, is there any effect at all on medical legal issues driving the high C-section rate? And second, if there isn't, is there a similar underlying parallel that is driving it beyond what you think is medical legal?
That's a great question. To the medical legal question, I actually think a lack of accountability in Bangladesh is driving this. So there's not a lot of fear of litigation among providers. However, there is a lot of feeling like their hands are tied, and they have to see 60, 70, 80 patients, and if you look at when the C-sections are being done, this was interesting, and I didn't say it, but it's almost all of the C-sections for fetal distress, which is something you would expect to happen somewhat randomly, were done between 12 p.m. and 6 p.m., which in the course of the clinical day, you finish rounding in the morning, and then you do the C-sections in the evening, and then they go to their private clinics and do more C-sections. I think that's a big driver, which is, I mean, the implications of that are somewhat sad, to be honest, but anecdotally, speaking to women, that is a driver. Actually, the person up here on the left had that happen to his wife about a month after we finished this analysis, as he went in and really got pressured to have a C-section for very unclear reasons. I think that's a main driver. I don't think defensive obstetrics is a huge driver, other than it's how it's taught, I think. Did that answer your question?
Yeah.
Okay.